Hey everybody, today we're going to be talking about bowel obstruction. There are two types of bowel obstruction, small bowel obstruction and large bowel obstruction. Both occur due to the blockage of flow of intestinal contents and have a high mortality rate, as high as 30% when strangulation or perforation occurs. High yield history, that's important. Stereotypically, patients will have crampy, intermittent abdominal pain, often accompanied with distension. They might also have nausea and vomiting with the absence of bowel movements or the ability to pass gas. They will also most likely have a history of abdominal surgeries, as high as 50% of cases, malignancy, and IBD, though these things are not always present. On physical exams, you're definitely going to want to monitor their vital signs for signs of sepsis. This includes fever, tachycardia, tachypnea, and hypotension. On your abdominal exam, you might pick up abdominal distension and tympany. But changes in bowel sounds, something that's often present on tests, is pretty hard to pick up in the clinical setting. You're also going to want to check for hernias, and whenever you do find a hernia, you're going to want to see if it's tender to palpation, reducible, and if there's any overlying skin changes, because this will help you decide between if it's reducible, strangulated, incarcerated, etc. And on top of that, you're going to want to look for peritoneal signs like rigidity and rebound tenderness, because these are signs of perforation, and if you find these, you should definitely go tell your attending as soon as possible. The differential diagnosis for bowel obstruction includes a lot of intra-abdominal complaints like ascites, mesenteric ischemia, perforated viscus, intra-abdominal sepsis, post-op ileus, appendicitis, cholecystitis, gastroenteritis, and diverticulitis. As you can see, there's a lot of inflammatory conditions, so that's definitely something you're going to want to keep in the front of your mind. Also, you're going to want to rule out in all of these patients abnormal presentation of myocardial infarction. Again, your diagnostic approach should fit the differential diagnosis you've created. So the labs we're going to start with a CBC to see if there's a leukocytosis, which will reflect some of the inflammatory conditions we've listed. We're going to get a BMP because these patients are vomiting, so they might have electrolyte derangements that we can correct. We want a lipase so that we can help rule out pancreatitis, LFTs to see if they have any gallbladder pathology, a lactate because that will help determine if they're having any ischemia or intestinal ischemia especially, and a troponin to rule out MI. We're also going to get an EKG to rule out MI because these can sometimes present in abdominal pain and nausea, so that's something we don't want to miss. For imaging, we have a couple of options. An upright KUB is often a good place to start because it's quick, but it has low sensitivity and specificity. You're going to want to assess for free air under the diaphragm, air fluid levels in the bowel, and a lack of air in the distal parts past the obstruction. A CT is going to be what you want to identify the exact location of the obstruction and the transition points. And if there is no contrast in the rectum, that means that it's a complete obstruction. This is going to be about 90% sensitive. Ultrasound also has pretty good sensitivity, around 90%, and is 95% specific. Here, you're looking for dilated loops of bowel that are filled with fluid, and these are going to be greater than 2.5 centimeters. You can also look for characteristic back and forth peristalsis. Here are some examples of imaging that demonstrate what we just talked about. On the left, we see an abdominal ultrasound looking for small bowel obstruction. We see that there is a dilated loop of bowel greater than 2.5 centimeters. We also see something called keyboard sign, which highlights the plicae circularis, which means we're actually looking at the small bowel. Another sign that might be present is called tanga sign. This is a hypoechoic outlining of the bowel, which means there's fluid outside of the bowel. On the right, we see an upright KUB. Though we don't quite see under the diaphragm, that's where we'd be looking for free air. We do see multiple air fluid levels and no real air in the distal colon. This is a really cool ultrasound because it highlights some of the things we just talked about. We're able to actually see the back and forth peristalsis. If we were to measure that, it looks like it would probably be greater than 2.5 centimeters, and we see keyboard sign present. There are multiple etiologies for bowel obstruction, and these change whether you're talking about small bowel obstruction or large bowel obstruction. These are important not only for diagnosing bowel obstruction, but important for history taking because they can often guide your questioning. Understanding the management of bowel obstruction is really important because this has a really high mortality rate. Getting a surgical consultation early is important because they're going to be in the driver's seat once your patient is admitted. Next, you're going to want to make your patient NPO for bowel rest. Then consider pain and nausea control. You're likely going to be using IV medications because these patients will likely not be able to tolerate anything PO. Zofran and morphine are popular choices. Then think about IV fluids. Because these patients have been vomiting and likely third spacing in their bowels, they're likely volume depleted. Consider 2 liters of LR as a good starting point, but keep in mind other factors in patients' history like heart failure. You don't want to overload certain patients. Then, because you got a BMP, you can start correcting any electrolyte abnormalities they may have, likely hypokalemia. A good place to start here is 40 milliequivalents of potassium IV. Then, if there's any concern for perf, you're going to want to go for antibiotics. Patients with obstruction are likely going to get admitted, but their management is probably going to be up to the surgery team. They'll be admitted with a nasogastric tube for bowel decompression, and if they fail this, they'll likely be headed for surgery. Recurrent bowel obstruction may present with partial obstruction that resolves, often when these patients are in the waiting room or actually in a room in your ED. These patients need strict return precautions. If symptoms return, they should come back. If they start vomiting, having severe abdominal pain, fever, or anything weird starts happening, they need to come back immediately. To wrap up our discussion of bowel obstruction, we're going to talk about some practice pearls and fast facts. Small bowel obstruction in a patient without a history of abdominal surgeries should be worked up for malignancy or IBD, even if you're not the one doing it. Elderly patients always get a rule out of the heart stuff. This includes the troponin and EKG we talked about earlier. If a patient isn't passing gas or having bowel movements, this does not mean obstruction. Finally, whenever you're getting a CT scan, most of the contrast agents you'll be using can be therapeutic because they reduce edema and promote peristalsis. The most common is gastrografin. These are the resources I use to learn more about small bowel obstruction, and if you want to learn more, I think these are a great place to start. Thanks for listening.